Conversations with Shem. Our focus is to show how to put the human back into healthcare. You're about to watch an episode in the 6-week series where I interview doctors about the health crisis in America today.
Hello, everybody, to another episode of Conversations with Shem. Now, I'm Donna Corriel, the creator of SoMeDocs, and I am very excited to be welcoming both Shem back to the show and a new physician panel that has graciously agreed to join us to have this super important discussion. All right. Please bear with me as there is some technical difficulty going on here that I'm trying to fix. Live shows are hard to do, guys, so thank you for your patience. Okay, so if you are interested in watching this episode after it's filmed or any of our other episodes until now, we've got 6 total in this series. Check them out on SoMeDocs.com under the series section. Under that section, you can find the video in the episode that you are interested in. So that's going to be exciting. All right. So this week, today, we've got Drs. Hafiza Khan, Dr. Kimberly Greene, and Dr. Kaveh Hoda joining us. So I'm going to be introducing them individually when it's time for our panel. So that's going to be exciting. Don't forget to interact with us during this live show. We really value what everybody out there thinks, and it's so important for us to bring that in and add texture to our conversation because we need to start these discussions and we need to have them on a larger scale. There are, as there always are, there are 4 parts to our show. There's Shem Speaks, there's the panel, there's a Q&A, and then there's a reading from Shem's new book called Man's Fourth Best Hospital. All right, so without further ado, I am going to bring onto the stage Shem.
Hi there. Thank you, Donna. Great job doing this. Thanks so much. A topic that I've never seen done before, really, for any length of time. We're here talking about putting the human back into medicine. All right, so and connection, isolation is deadly and connection heals. That's how to put the human back, basically. What is inhuman? Well, Roy Bash, who is the hero of the House of God, at the beginning of the sequel to the House of God, Man's Fourth Best Hospital, says, "I'm called to write this book because it's a time when medicine could go either one of 2 ways, either toward more humane care or toward money and screens," which means money and money, because what people don't know, but we do, the screens are billing machines. So that was the reason that I really jumped into this, to try to see what I could add to what's going on. And the result is that there's a real epidemic for doctors, nurses, and patients, which we call burnout or moral injury, or what I like to call is just abuse by this system. And it's only better for the insurance industry and for these chains of for-profit hospitals that we see sprouting all over the country that are run not by doctors, but by MBAs. They're the CEOs now. And so like what I felt when I started to write The House of God, I said, this is so awful. Somebody has to write it, and I guess it must be me. And I knew that it was so bad that in order for it to succeed, it had to ride on humor at the beginning, and then it gets darker and darker. And I'm the most surprised guy in the world. I never even thought it would get published, and here it is 42 years along. So I'm very happy with this. And I was called to write man's fourth best hospital, because all of a sudden, after having been out of medicine for years and just being a writer, I got a job. I was offered a professorship in medical humanities at NYU Medical School, which is just a wonderful place. Man's Fourth is not at all about that. But the first day that I was on the wards, I noticed two things that really got to me. And as I said, they're money and screens, which is billing. And so what happens in man's fourth best hospital is trying to address the difficulty and trying to show how to do it better. And that meant really learning about money and healthcare. And I spent months doing that. In the middle of the book, the fat man is giving a lecture to his team. He gets most of the central people from the House of God in to work on this clinic, and he gives a lecture that's called "The Six Rackets of American Healthcare: Follow the Money." And for me to come to understand this took months, and I think I tried to get all the interlocking pieces together. So and then at the end, it was my duty, if I'm taking this on, that's what I felt, this task, it's my duty to find out the truth about these six rackets. And then at the end, what to do about it. How can healthcare get more humane? And you have to read the book to see how that happens. And The House of God was a resistance novel, resistance to an injustice system and training. This is a resistance novel that's looking at resistance to the system and what it's doing to harm doctors and patients, etc. And the two main things I would put out right now that really matter in keeping human is, as I said, the danger of isolation, the healing power of good connection, but also the idea of don't get isolated, stick together no matter what. And I'll at the end of the show, when I'm talking about man's fourth best hospital, I'm going to read a little piece in the book that shows how resistance to this unjust system happens in the novel. So I'm just thrilled at this. I can't wait to hear what everybody has to say.
Fabulous. Okay. Thank you so much, Shem. We are going to see you very shortly. And so I am going to be transitioning over to the panel. All right, so without further ado, I'm going to be introducing our panelists. The first is Dr. Hafiza Khan, who is a board-certified cardiologist and cardiac electrophysiologist. She's a graduate of UCLA School of Medicine and has trained at UCSF and Brigham and Women's Hospital. Welcome to our show, Hafiza.
Thank you for having me.
Absolutely. We are thrilled to hear what you have to say. All right. Moving on to get everybody on here. The next person I'm going to bring up is Dr. Kimberly Greene, who is an emergency and urgent care physician with over a decade of clinical experience and who also holds a Master of Public Health in Epidemiology. Welcome,
Hi.
Kimberly, Dr. Greene. Hi. It's great to have you here. And then last but not least, on our panel is Dr. Kaveh Hoda, who is a physician, musician, and podcast host in San Francisco. He co-hosts the humor-adjacent medical podcast, The House of Pod, which is just so relevant. Welcome, Kaveh, Dr. Hoda, to our panel.
Hey, everyone. Thanks for having me.
Sure. All right. Without further ado, I'm going to bring up Shem and I'm going to remove myself, and I will see you guys soon in the Q&A section. So here's Shem.
Kaveh, I think we had been in touch at some point, weren't we? Yeah. House of Pod or whatever, right?
That's right. There is that relationship. We did brazenly steal that title from you. And thank you again for not suing us.
Great. It's good to meet you face to face. I just am so thrilled to have this chance. You know, at my age, I'm such a lucky guy. For about the last 10 years, I've had as my signature gratitude. You know, that's what I walk around with. So let's have some questions, answers, anything you want. I mean, it's wide open and we'll just talk. How about that?
Sounds good.
Any comments on anything I said, or?
Yeah, I'm sure. I mean, I don't want to jump ahead of anybody, but you know,
Go ahead.
I definitely think it's an interesting point that you bring up isolation as one of the major problems, if not the major problem, because that was an issue before COVID, and now it's taken on sort of a different meaning during an age of COVID.
Mhm.
As doctors, we still work in the hospital, we still see people, but there's certainly that extra new sense of isolation that we feel. How are you in your courses and your teachings? How have they changed now in the setting of COVID?
Yeah, that's exactly right. I mean, I'm not on the front lines anymore, but over and over again, people talk about how totally isolated it's like a pantomime almost with the patient now. It's a terrible thing, and I'm not there. So if any of you have been doing that, I'd really appreciate your jump in now, because I have.
It's interesting you could say it, because so I actually left clinical practice over the summer, and there's a lot of reasons for it, but I was in the emergency room up through August. And one of the things that I've noticed over the past, really mostly over the past 5 or 6 years, is that we're so siloed that I have no relationships with other doctors unless I make an effort to do that outside of the practice of medicine. Because we're encouraged to work with these silos of, nurse practitioners and nurses, and they're wonderful. There's some great people. This is not a denigrating kind of comment, but when they say to you, do you have physician references for your recertification in a hospital? I don't even have physician references because you don't work with anybody. They say, who do you work with? I'm like, I don't know. I don't work with anyone. No one talks to me. No one, it's not that no one says hello. It's just you're so isolated in your practice that you have no interaction with anybody else, even in the ER, and you know how many people are in the emergency department.
So I have a little different experience.
Mm-hmm.
So I'm a cardiac electrophysiologist. So I'm not isolated at all. The hospital has been my happy place. At lunchtime, we have a doctor's lounge. That's my time to meet with the intensivist, the cardiac surgeons, the anesthesiologist. So the office is isolating. I'm in my little room, but as a EP, I'm in the hospital 3 days a week. So I love that because I'm meeting people all the time. But now with COVID, I can't eat in the doctor's lounge anymore. because it's not safe for us to take our masks off together.
Mhm.
So my happy place of where I learn ideas and ECMO and what's the latest with this, talking to my surgical colleagues, that's been taken away from me. So I grab a sandwich and I eat in my car now.
Oh.
So I have been connected, and it's been a source of such joy for me to be with other specialists outside of the office. And now I'm eating in my car because I'm scared to take my mask off in front of my friends.
Wow. Wow. That's amazing. Yeah. And what work are you doing then actually now?
I'm a practicing cardiac electrophysiologist.
Uh-huh.
So 40% of patients with COVID have cardiac arrhythmias. So
Right.
I'm putting pacemakers, defibrillators, ablations, and I'm in a multidisciplinary hospital with cardiac anesthesia, interventional cardiology, structural. So our gathering for coffees and in the break room, this has been a source of joy and connection for me. And this last surge, the first surge, we were shut down and nothing happened here. I'm in practice in Dallas.
Mhm.
The second surge, we were careful, but we kept the tables, 6 feet apart. This next surge, it's not safe for any of us physicians, to eat in front of each other without a mask anymore.
Yeah.
So, or what about the EP nurses, the nurses in the electrophysiology lab, the techs? So we go to the break room in between cases, and this is how I connect with them as human beings. But we can't take our mask off to have a sip of coffee with the nurses and techs. So we're so alone. We to have to eat and drink food alone in hiding. It's
Oh, wow. That's really something. Yeah.
it's horrible. I can't even describe how that feels.
Yeah. Yeah. Anybody else?
I mean, I think that, the COVID issue is a real issue. When I think about, it's interesting, I was talking to Dana before this podcast earlier today, and we were talking about how the issues in different specialties are so different. What you do as a cardiac electrophysiologist is vastly different from what somebody is going to do in a primary care office or what I was doing in the emergency department. And in some ways, that complete difference in practice makes it hard to relate to what somebody else is experiencing or going through, because our experiences are so individualized. So when I was talking about the isolation in the ER and in urgent care, I think there's been this big push. It's what's your door to doctor time? What's your door to discharge time? And the same is true whether in urgent care as well. And that push means we never have breaks. We don't, there is no break to sit and have coffee with somebody else. So that isolation is unfortunately not a COVID thing. It's an everyday thing. There's a push to see more and more patients. I had one place I worked that wanted us to see 7 patients an hour, which I just think is unrealistic.
You had to see seven patients an hour?
Yeah, one of the places I worked, and which I'm not working at anymore. But I think when you have that, you don't ever interact with other people, and it becomes very lonely.
Uh-huh.
But that's emergency medicine and urgent care. That's not necessarily what's going on in other fields, but that's an issue for us.
I think it's an issue in some ways for everybody at this point. Shem was addressing this before COVID, this moral injury that doctors have. I am really concerned about what we're going to see happen to the medical profession after this.
Yeah.
I mean, we've already seen people decide that they want to leave clinical medicine. People are taking more consulting jobs, and those are all important things. But I am really worried about what's going to happen to the state of medicine when this is all said and done.
Yeah. I actually have been thinking about trying to write an op-ed piece on, do we really want to go back to what was as doctors? Because this isn't, the corona has sort of focused everybody, but what we all know is that medicine was sort of going along with a lot of problems, a lot of suffering. Let's use the word suffering. Doctors don't use the word suffering. It's interesting. You don't ever ask a patient, what are you suffering? You know, and I've always thought, this is a digression, but I've always thought it would be helpful to use the word suffering. What are you suffering? Because suffering is what the doctor and the patient always, I mean, we all suffer, right? This is the Buddha. We all suffer. And to put that out between a patient and you, I think maybe could make, you know, a good connection. But, you know, we really have been going in a very difficult direction, no matter what kind of doctor you are, before all this happened. And it's funny, like this is moving us over into another thing, and we can't really focus on what we were doing before too much. But we know, hey, things were not so good then. You know what I mean? We're in a very confusing time, I think, right now as doctors. I mean, eventually, you know, the COVID will die down, but these things that I write about, which was pre-COVID, are going to be there. You know, we've kind of not taken control of what we need. You know, I don't know how you all feel about that.
So, as a cardiologist and cardiac electrophysiologist, 70% of American cardiologists are employed by healthcare systems and large corporations. We don't all have the autonomy to take control of those things because we are employed, and that's part of the moral injury. So the things that we could do, which are have family conferences, have 5 people. I do talk about suffering. As a cardiac electrophysiologist, I bear witness to life and death.
Good for you.
I bear witness to the miracle of survival after sudden cardiac arrest. And I have families of these people with me as I talk to them about withdrawing support. I'm used to that. We cry together, we laugh together, and we celebrate the joy together. But now that's been taken away from me. It's also been taken away from the family and the patient because we can't have all the family there as someone is passing and I turn off the defibrillator. So you go home and it is bad. It is hard to witness suffering. And so we talk about this, but the more you talk about it, you relive that trauma as an electrophysiologist. Sometimes you have to bury that in order to be able to move on. And my husband is not a physician, so he doesn't understand those things. So my support is my 8 partners, and now we can't even meet at coffee to talk and unburden ourselves.
Yeah. And your life in the bigger corporation that you're being employed by, is that a change from what you did before?
So part of the reforms of the Affordable Care Act diminished payments for echocardiogram, stress test, and office-based testing for cardiology groups. So the thought was that us cardiologists are ordering unnecessary stress tests and echoes in the office to line our own pockets. So the payment shifted to the hospital out of the doctor's office. So it drove most cardiology practices out of business. But it turns out the number of stress tests and echoes has not decreased. And it wasn't lining our own pockets that drove that, it was need. And now the hospital is generating that revenue. Most cardiology practices no longer have that revenue. So we've all sold to the hospital system across the United States. So we don't order tests for the $200 that the echo truck makes. We order tests because cardiovascular disease is the #1 killer of Americans until this last month. Yeah. So the reality for most cardiologists, cardiac electrophysiologists, is that we're employed, but it has been a safe haven in COVID because we can't be out of practice. heart disease and heart attacks don't stop for this pandemic. And in fact, they get worse because of plaque rupture, stress. And so there's goods and there's bads with it, but and it's reality. So we move on. But a lot of the support within the corporate structure is now being taken away from us in the human part for the physician, not just for the patient. And that bleeds through down to those that we care for.
Yeah.
And I think corporate medicine is, there's nothing good about it. I mean, it's nice that you have access to greater resources, but you're driven by metrics. You're driven by a million middlemen between you and the CEO. You know, there's somebody who didn't go to medical school giving me an instruction on what I have to do to get from point A to point B. Someone else is making decisions. You know, it's interesting because one of the things that I'm very interested in switching into at this point is more of a population health kind of role, because there's so many barriers to people actually getting what they need that as an individual physician, I can't do anything about that. Working in something like population health, you have a better opportunity to affect a whole system's worth of what happens to these people. But the fact is we're all working in these systems and they make demands of us that are unrealistic, inhumane, stress-inducing, you know, all the things we've been talking about.
Yes, but if physicians like myself who care about our patients, care about their patient's family, leave clinical medicine, what's left?
That is a problem. That's a problem.
You know, there's not someone at the bedside is what I have done for 28 years. And I'm never leaving that. That is my life's purpose, is to bedside caring. At the end of the day, I go home and this is my vocation. That's the moral injury part, right? That this is my prime directive. I graduated medical school in 1992. This is all I know.
Yeah, yeah. Yeah, you had something to say? I'm pointing at you.
Yeah, I was going to say, it's actually, Dr. Khan brought up a really interesting point, which is the extra burden there is of watching patients suffer in isolation. And I was talking to a nurse that's in El Paso and was working the ICUs there, Ashley Bartholomew, and we were talking about that. There is this new heaviness to watching patients die. I mean, ICU doctors, ICU nurses have seen that forever. But the new component to it now is that they're doing it in isolation. They're doing it alone. And there's an extra burden on the healthcare provider during that situation, because what happens is you're not getting that normal closure of watching a family get closure. They're not there at the time. They're not there to make that that passing, you know, more humane. And that is one of the things I think is really going to leave long-lasting effects and scars on our healthcare workers. That really concerns me. I don't see there being a great way around that, unfortunately, until we get this coronavirus under better control. But that is that isolation is a really interesting, again, factor that we now have to deal with as doctors and nurses.
Yeah, well, that's just an exacerbation of where we were headed, right? Because all of the burnouts of, actually, I looked this up and wrote an article about it. When somebody did a study, I can't remember the names, of the three symptoms of burnout, and they tried to find a correlation with these three symptoms. And the only thing they found that correlated was in 2008, when Obamacare came in. And that was because, not when Obamacare, yeah, when they did the computers, right? When they went to computers. And so I think it's a pretty clear line from that moment to the thing about the electronic medical record was that it was fine what Obama wanted to do, which is to do it for data. That is, and you know, the transmission and registration of data is absolutely terrific. That's what we want to do. That helps everybody. The problem was when the insurance companies got their hands in there and put a monetary value on each piece of data. And if somehow that hadn't happened, I think we'd be in a totally different place now, because that's what it's about.
I agree with you. So, again, as an EP, I'm in the office 2 days a week. So in the hospital, I see what I spoke about. But the electronic medical record, when somebody uses their mobile device, cell phone, and drives, or when they eat food and drive, we call that distracted driving because it's dangerous and can result in accidents.
Right.
A computer in the room with a doctor typing, that's distracted doctoring. It takes over from the focus of the main reason that we're in the room, which is the patient. So having to type or dictate or in any way interact with that computer is distracted doctoring, and it's disruptive just the way using a cell phone is when we're driving.
Yeah, that's a good point.
So interesting, because when I started out, when I went to medical school, I was in Philadelphia, and they had an early version of electronic records before they had them in New York, and I live in New York now. And what we used in Philadelphia was really basic and easy, and I thought it was this great system because at the time it would check your drug orders to make sure you didn't make a mistake, which was helpful. And then I came here and we instituted electronic medical records every place, and they became this behemoth. And they were totally different from what I remember, actually appreciating in the 90s. And being able to type a note when you could first type a note, that was nice because my handwriting is abysmal. But what they are today is not what they were when they started out.
Yeah, I got a letter from somebody who read Man's Fourth Best Hospital, and he knew about the Veterans Administration. He was in the Veterans Administration for a long time, which of course is nonprofit. They're not billing, well, not like we bill, but they're each diagnosis more or less has the same payment as all over the country, and so there's no dickering with insurance across the screen, right? And so they really they had a pretty simple computer there for years and years and years. And I just got this yesterday. These guys that they got this idea they couldn't privatize the VA, so the VA still is what it should be, but the Cerna, I think that's an Cerna or something, EMR, sold to the veterans for $9 billion, this system. So they're still, now they have this horrible system, even though it's not billing. I don't know what they're doing with it. It's crazy. But I think let's turn a little bit to what I mentioned before, resistance, because it's like I've said this before. Has any of us ever seen when we went to the theater in the old days, if someone fell down on stage, the cry go up, "Is there an insurance executive in the house?" I mean, it's so crazy because I'm a 60s guy, and we did put the civil rights laws on the books and ended the Vietnam War, just by sticking together and believing. I can't stand the fact that we can't get together. Doctors get together and say, "Hey, look, we're the workers." Like the nurses do. The nurses never lose a threatened strike. They almost never have to go out.
You know what it reminds me of? It reminds me of those nature videos, like where you see a lion hunting down like an antelope or something. In most of those cases, 95% of those cases, what always happens is the lion catches a straggler. The whole crowd runs, they run away, the one's slow and it gets taken. But in those rare situations, in those really rare situations where you'll see like a couple of these animals will stick together and fight back, they always win. And it's like that with doctors. Doctors tend to run. It's because we're risk averse. We don't, as soon as there is a threat or something scares us, we run like a pack of wildebeest or something that are scared by a predator.
I also think it's very hard to organize. I spent a lot of time kind of working with people to set up groups and affiliations and getting people to come together on a focused platform. Like, let's say your focus is you want to change things in EHR so that they are less burdensome, and that's your focus for now. There tends to be difficulty keeping doctors, and everybody really, but doctors in this particular case, focused on an objective. And so it's hard to bring people together because people tend to want to bring in things that aren't necessarily related to whatever your core objective is. And then moving the needle and coming together becomes impossible.
Well,
that's why we have our societies, the American College of Cardiology. These are collective organizations that are supposed to look after our interests. The Heart Rhythm Society, as an electrophysiologist, we can't save all of the world's problems when we're trying to save lives at the bedside as well, and pay off our student loans and take care of my children and my family. I'm a mother also. How much can I do before there's nothing left in me? So I just need to focus on getting, my priority is two things: my patient and my family. I can't save the world's problems because there's just not enough of me to give. And so my attitude has been, I put my head down, and if it prioritizes my patient, I'm willing to be in that meeting. Otherwise, I have to be with my family. I can't be on any more unpaid committees on the EHR. Either I save lives, I save my patient's life, or I protect my life and my family's. Those are my only two priorities anymore.
yeah. I mean, doctors, everybody knows this. It's so hard to try to organize. It's very hard. And the nurses, I think forgive me if anybody's sensitive to this, I think it's a little bit of a gender difference, because women are much more, in general, to gather together and maybe do things, and they have a very strong union.
That's because nurses are heroes. Every single Pew study for the last decade, the American public has viewed appropriately that nurses are the most trusted professionals.
Really?
Because they are true heroes. So it's got nothing to do with gender. It's the fact that what they do, especially now in the era of COVID, God bless them. Bedside nursing in the era of COVID, wearing an N95 for a 12-hour shift.
Yeah.
They are heroes. I get to wear my N95 and then run to my car, take it off for a breather, have a sip of water, run back in. But so it's more than that. It's that there's such a diversity amongst different specialties that have different vested interests.
Mm-hmm. Yeah, I think that's true too. You know, it's definitely an issue, because what the American College of Emergency Physicians is advocating for may not be directly oppositional to what the American College of Cardiology is advocating for, but they aren't the same things. And it's a shame, because I think if you could get these, and even within the professional associations, I mean, I don't know what it's like for you guys in your professional associations, but within, ACEP, we argue and we don't like things that they're doing sometimes. Even getting within those organizations, getting them to come together to support things would be helpful. And I think a lot of times they don't even do that.
Yeah. Well, we have, thank God, a receptive president as of 30 days from now, who wants to do something about healthcare, and he's got great people with him. He really does now, and I think there's a room. Certainly, the simple step, which will of course not be simple to do, is just a public option, tacked on in some way, because we can't go on like this. We can't go on like this. Patients can't go on like this. And at that point, I think we doctors will have leverage, if people want to do that.
In 2006, we thought we had a receptive president, and what had started off as a well-meaning, great idea to get more Americans health insurance has morphed into something that has been catastrophic for several aspects of medicine.
Yeah, and I'm not
in the details that are tacked on to these bills.
Yeah, that's my concern with the public option, because I think that while it sounds good on paper, at the end of the day, you're trusting politicians to make decisions about what kind of care people get. And while I understand and agree with all of the arguments against insurance companies, I'm not going to argue. I think they're problematic. I'm not sure the public option is a better option than that. I think that this is a really complicated system. I don't think that there's any simple dismantling that can occur because we have decades of bad policy. You know, what you described with the cardiologist and putting the procedures into the hospital, you know, rules about doctors owning hospitals and facilities, you know, rules that don't, you know, we've just had a change in the way pharmaceuticals are reimbursed, but we've had these pharmacy benefit managers, you know, Marion Mess talks about this all the time. You know, there are so many little pieces to this puzzle. I don't think there's a simple fix, which doesn't mean that we shouldn't try to change it. I just don't think that one thing is going to fix it.
Well, there, you know, to be fair, there are a lot of doctor groups in some ways that are, and think tanks and everything else, and very pragmatic people too, who are going to be pushing and are going to be pushing, and this may be a window to get something more. How would you, I mean, what would you do, even when things get more normal, how would you like to see medicine practiced? What would make it better for all of you, for all three of you?
I think there are some things that we can learn from this, from the pandemic going forward. I think that a simple thing that I think a lot of us have learned as doctors is that you don't have to you can do some things remotely. A lot of things can be done remotely. I think that's one very basic thing going forward. Sure, some clinics will always need to be in person, but some don't. A lot of video visits work really well for patients and for doctors. I think that is a simple thing that can be done that can improve a lot of our lives, cut down on commutes, get people at home more. And I think there is some chance for restructuring after this as well. I'm a little bit more optimistic about the public option. I'm a little bit more optimistic about going forward with this new administration. I think a big part of the problem we had last time around was there was a lot of, and at the time I thought it was a great thing to do. A lot of compromise was made to try and get as many people on board as possible. And at the time I thought that was a good idea, but it turns out that probably didn't help in the long run. And maybe something a little bit stronger has to be done this time around, and hopefully it can. We'll see. I'm not too optimistic, but I certainly have some hope.
Yeah. So what keeps you going?
The patient. So what the patient is the sun, and I as a physician revolve around the patient, and then the nurses, and then the administrators, and then the billers. That should be Pluto, and the patient is the sun. What has happened is that the biller is the sun, and I revolve around that, and the poor patient is out in Pluto. How has this become the center of what we do? Has become the most distant part of what we do. And we have these acronyms. It's not the HPI, it's the history of present illness. Right. I am taking a history. I am listening to what the patient says. I'm not locking an encounter. What is an encounter? I am finishing my assessment of a person who has a potentially lethal cardiac arrhythmia, and my history involves listening to the patient tell me the story.
Yeah.
So these words that we use, SOPNO, HPI, encounter, they have masked what our purpose is. The patient is our sun, and we revolve around them, and the entire system should as well.
Uh-huh.
That gives us joy. That gives us fulfillment.
So that vision keeps you going. Yeah.
I have a son who's a pre-med student. I have two sons, 24 and 21. And my 24-year-old decided not to go into medicine because he was a scribe in an emergency room for a year.
Uh-huh. Uh-huh.
And he witnessed toxic masculinity. I have two boys. He witnessed what the jokes that were made.
Yeah.
He witnessed the burnout amongst those physicians. He is now going to get a biochemistry PhD.
Yeah.
My younger son, who is a junior at the University of Chicago and still a pre-med, hasn't dropped out yet, but the future is in people like my two sons. And, Dr. Greene, I mean, emergency medicine physicians are burnt out a lot. They don't start that way. And my son witnessed that, the jokes, the gender jokes, the jokes about ethnicity. And he told me he never wanted to be a doctor like them.
And we have that. My issues with the ER were less about that and more just about it's the because that actually wasn't really an issue any of the places where I was, but it's volume and outsourcing and lack of support and metrics and I think that one of the things that's also a big problem, we're talking about the whole issue of humanity in medicine. I think that what I would love to see, and I'm not sure this will happen, is I would really like to see more of a role for physicians in medicine. And, I have worked with some wonderful nurse practitioners and some wonderful PAs and some wonderful nurses. But at the end of the day, I think that physicians should do the physician job. And I think that that would go a long way towards improving our ability to connect with our patients if we're the ones taking the history and getting the information and doing the exam and doing the assessment. It also makes you better able to make decisions because, I think that one way to make this better is to stop outsourcing this to other people. I don't know how we do that, because I think that this structure of having other people involved has become ingrained, and we have fewer physicians at the top. And of course, then you talk about someone like me, and I just left, so I'm one fewer. But I think that would go a long way towards improving patient satisfaction and improving physician satisfaction.
We have a physician shortage in the United States.
You are correct. Again, this is a dream. This is not a reality. But I think it would be better if we could do that.
So we have a physician shortage in the United States, not just MD and DO. We have to import 30,000 international medical graduates to fill the shortage. And yet I have a son who is stressed out because he doesn't have enough first author publications as a junior in college to get into med school. We have raised the bar so unrealistically to be able to get into medical school. My son has 5 publications, but he is second author. He doesn't think he's going to get into a med school if he's not a first author.
It's crazy.
So my older son who dropped out did have 3 first author publications. The bar has become so high to get into a US MD program. How we have made the MCAT score ridiculously high, yet we have a physician shortage and wonder why there are not enough physicians and we're relying on PAs and NPs. Right. We need more med schools. You don't have to be a genius to get into medical school.
Well, yeah, I think, there's certainly a lot wrong, and we need a lot of these things to be changed. And the for-profit motive that stretches through all of this, it's obvious that what NYU did has to be done for other medical schools. It has to be free tuition. When I've done 50 or 60, I don't know, commencement talks, and I always ask at medical schools, I always ask, if you were offered the deal, if you did a year or 2 in public service someplace in the United States after you graduate, if they got rid of your debt, would you do that? And of course, all of them say yes to a person. They say yes. I mean, these are not hard to get. I think, I'm a silly optimist, I think this is a window of opening, when the COVID hopefully goes, in this administration. And they are much more open and are going to fight much harder for a just healthcare system. That's what, Biden is for that. And Murthy is a great guy who's a Surgeon General. I know some of these people. And also, let's not forget, there are organizations, there's not a big one or organization, but there are organizations who are really hammering to try to get some of these things done. And now is the time. I mean, I know I'm not on the front lines, but I know you're all worn out. And all of the things you're saying are really hard to deal with. And the one thing that is necessary in fighting this fight, because it is going to be a fight, is we can't scatter. We can't get isolated from each other. We can't get isolated from our loved ones. We can't get isolated from our patients, although that's a problem right now. And I think I'm the most hopeful that I've been, for many, many years about this, just because it's gotten so bad. The only thing that I held on to with Trump and all of that stuff was, I say to people, this is how change happens. This is how it happens when it gets so bad, really rocking the country. This is the hope. This is when hope actualizes. So I'm bringing a 50-year awareness to this, and it's hard. Don't get down and stick together. Stick together.
Well, I think that in the 28 years that I've been a physician, and as I see my sons entering this, there's only one mantra. Several people call themselves doctors, but we are physicians, and our purpose is to heal. Physicians are healers. I am a healer. So when it gets overwhelming for me with the EHR and the billing and I get behind on my notes or my inbox, that's my mantra. I am a physician, and my purpose is to heal.
Well, I've always thought that heal is a very interesting word, because it goes both ways. Heal me, heal the patient.
Not cure, we heal. Heal is is a word that encompasses, Dr. Shem, what you say, humanity.
Yeah.
We are healers, and that's what it means to be a physician.
Okay. She's here.
Oh, sorry, I was muted. So I think with that, it's a good time to, I actually didn't even have time for Q&A, but you all covered so nicely this topic, which clearly we have to continue discussions on. So everybody from the panel, thank you so much for joining us and taking the time out of your day. I'm going to take you off of the stage in order for Shem to read an excerpt from his book. But again, thank you for taking time out of your Sunday.
Thank you.
Thank you.
Thank you, guys. Thanks for having me. And Shem, great to see you again.
Great. Nice to see you.
Great. All right. Bye-bye.
Well, that was intense for sure. As I said, resistance is important, and resistance is why I wrote The House of God. And that's the reason that I wrote Man's Fourth Best Hospital. And I'm going to read you what may seem bizarre to you. Remember, this is a novel, but this is a kind of in this huge fourth best hospital at the Fat Man's Clinic, the public clinic. This is a resistant moment, and you'll see why. Let's see. Roy is seeing a patient, and he's really, the computer isn't working terribly well. So he says, scared to death of losing my work, I pressed save. Instead of the usual message from the screen, when I had successfully sent my outgoing data, there now appeared error, not saved in bank, cannot connect to server. And all the boxes went blank. When I got to the nursing station, all the others of the clinic were there. It had happened to all of us. Fats was on the speakerphone talking to our IT guy named Joe. He hung up and faced us. Joe says the problem is in the Fat Man Clinic link to the Heal server. No other disk linkages have been reported in all of man's fourth, just us. He shook his head, puzzled. And here's the spooky part. Incoming is fine. We can still receive data coming in, but outgoing is gone. Weird. The good news is that all the patient data, the results of lab tests, procedures, admissions, etc., will continue to come in. So we'll have all the clinical data we need. He paused. But we will not be able to click boxes to send out anything, we write, in HEAL, the electronic medical record. No histories, physicals, test orders, or prescriptions. So we'll handwrite all of these things for now and have our lab tests, etc., carried by messengers I'm going to hire and have running around the hospital, like in the old days, right? As we absorbed this, Fat sat, head down, eyes down, strangely still. And then all of a sudden, it hit me. And before I could say anything, Eat My Dust Eddie shouted, "Hey, hey, hey, no more outboxes to click. We can't bill. We can't bill." Cheers, joy, relief. Patients stared at us. We smiled and waved back. "Compañero," said Humbo, "let us give thanks in prayer to El Señor." He lowered his head and ridiculously and with patients watching, we all did so, with Humbo and Runt and even Eddie kneeling. "Dios y Madres, make this last for the rest of our lives. Amen." That afternoon was a treasure, all of us getting all the data we needed in from HEAL and not having to click box any out. We went back to tactile, pen and paper, lab slips, x-ray forms. We sailed through our patients with time to spare. When we ran into one another walking back and forth to the nursing station, we smiled and sometimes high-fived using words like heaven, bliss, heavenly bliss, and thank God Almighty, free at last. And of course, it was Sabbath. It happened as a resistance by a technocrat for that time, and gave them a little breather in terms of seeing their patients. And next week, I think we can talk, and I'll take pieces from both books about resisting this system. And as I said just at the end of the other part, things are really bad in healthcare because of the COVID right now. When we're done with that, it's going to be bad for healthcare, but it is, I think, hopeful that we're going to bring change to the system. Thanks. See you next week.
Thank you so much, Shem. Everybody have an amazing Sunday. Come back to us next Sunday at 6 p.m. Eastern Standard Time. We're going to do this all over again, and it is our season finale. It's episode 6 out of 6, and so we are going to be wrapping up this series with yet another 3 physicians to discuss the same topic of putting the human back into medicine. So have a fabulous rest of your Sunday.